now we are already running late, so we want to start our program. So this is the monthly clinical program from the Bengal Yoga Society. This is a unique topic. Bladder battles, the female UTI story, which is very common in our day-to-day clinical practice. So it's give me a great pleasure to have Dr. K. Lalita from Hyderabad. Uh, Thank you, madam, for coming for a long and despite his busy academic and clinical schedule, she came us personally and physically for enlightening us regarding the female UTI. And she is MC's urologist and urogynecologist. She has 10 gold medals in all MBBS and top rank in from PGI Chandigarh in degree course. And she is also a director in Lalita's Urogynecology Center currently in Hyderabad. So without delay, I'll ask request ma'am to come and give your lecture. After that, we will have another lecture from. Before that, our secretary, president is not to come today. Secretary will give some small address, and then we'll start Dr. K. Lolitar lecture. Dr. Somo Mandal, please come here.
Thank you. Warm welcome to all of you on behalf of our president, who had been not been able to present here. And I really thank you all for coming here. You all know we had been continuously trying to make our presence felt, make all sorts of endeavor for the development of our society. And these today's program focuses on female UTI, the most common patients which we face in our OPDs. Before I would like to, going on to madam, I just like to take a few of your minutes. It will not be long. Please bear with me. And I must recognize Aileron Division of the Inters, who have been our partner in our academics. And thank you, Aileron, for helping us organize this meet. Well, UTI is one of the most common infections which we face in our OPDs. And normally, 50 to 60% of women have one or multiple forms of UTI in their whole life. And in all these cases, recurrence is common in about 25 to 44% of cases, almost in half of them. And one must say that most of the times, inadvertently or advertently, we prescribe antibiotics and antibiotics. Now, what is recurrent UTI? The recurrent UTI can be defined as more than 2 episodes in 6 months and more than 3 episodes in 12 months. And you must remember that complicated episodes almost recurs with the same organism. And what I must say that we are looking into we are staring into an epidemic of multi-organ resistant organisms. Most of the times in our OPD we have been finding the urine culture report where most of the organisms are resistant to everything. That's where the idea of drugs comes up, which are basically non-antibiotic and which may not develop resistance. And with that, the companies are coming up. And the recent development is that methenamine. Although methenamine is an old drug, it is recently being widely prescribed in UTIs. And the most common mode of action is methenamine is that it turns to formaldehyde and in an acidic urine and lyses the cell wall as well as the DNA of the organism, DNA or RNA of the organism. As a result, it acts both in the gram-positive and gram-negative libraries. It's an old drug. It has been discovered in 1859. FDA approval came in 1940s. The most common formulations are the heparate and mandylate, where heparate is the FDA preferred formulation. As I have told, it turns into formaldehyde, and this denatures bacterial proteins. resulting in bactericidal activity, and it only acts in acidic urine. So you must remember, before prescribing methenamine, the urine must be acidic, and for that, the heparate action comes in. Heparate turns the urine acidic. It is mostly absorbed from the GIT. Plasma concentration is reached at about 1.5 hours, and food does not have too much effect. And it is not bound to the protein urinary albumin, and mostly it is excreted. And therapeutic concentration is even in most about 2 to 3 hours post first dose. The heparate and the mandolate are the most common drugs available, where the heparate is preferred, with due to its better tolerability. And these are the dosing guidelines. In heparate, we normally prescribe 1 gram BD, and it can be given up to 1 gram TDS also. Doses is scheduled according to periodic dose. Normally for prophylaxis, we prefer up to 12 weeks, 3 to 4 months, and we monitor them with the urine culture, and blood urine report. And what are the main clinical indications? The main they are can be used in most patients who are in CIC, the patients with neurogenic bladder, and it can be used in pregnancy also. The side effects mostly are gastrointestinal nausea, dyspepsia. Dysuria is not so common, and gastric irritation may sometimes result in diarrhea. So the absolute contraindications are if the patient has a hepatic disease, if there is any sort of hypersensitivity, and the patient is having alkaline urine, where it will not act. And we must remember this, the drug interaction with sulfonamide. We should not use it with bacteria or any sort of bacteria, septum, something like this. It will not act. And it will result in formation of stones or obstruction. So what is the clinical evidence? The drug is quite old. Studies have been done as late as 2002, 2005. And recently, Cochrane review has been published in 2022, where the benefit has been shown to about 30 to 40% with heterogeneous evidence. Now, what is the advantage of this? It has least chance of developing resistance. Long-term safety is there, cost-effective. Another thing is that it prevents candidiaria, a fungal infection. Monitoring the drug is done by mostly the baseline tests like urine analysis, renal function. So what is the takeaway? This is done in, if you want to give a long-term antibiotic where most of the antibiotics are resistant, and the urine must be acidic. And our company's today's partners has come out with the heparis, which is methenamine heparate form, and is available. Thank you. Thank you for that.
Thank you, Somoda. Now our next presentation, the guest lecture by Dr. K. Lorida Madam on female UTI.
Good evening, everyone. At the outset, I would like to thank the Bengal Urology Society for this opportunity. Urinary tract infection is the most common bacterial infection, accounting for more than 7 million office visits and more than 100,000 hospitalizations per annum. And it costs the global economy more than $6 billion per annum. I'm not audible? You want me to raise louder? Okay. So the prevalence of UTI is 30 times more in women as compared to men. And the prevalence increases with increasing age and reaches the highest, the peak in the postmenopausal woman, reaching almost 40% in the postmenopausal woman. It's estimated that about 35% of the women suffer from urinary tract infection sometime in their life. Why there is greater susceptibility of UTI in women? Because of two factors. Because the urethral meatus is in close proximity to the anal canal, which is loaded with uropathogenic E. coli, from where the bacteria, these uropathogenic bacteria, can enter the urinary bladder because the female urethra is short. But why only few women suffer from UTI? Infection occurs whenever there is imbalance between the bacterial virulence and the host defense mechanisms. Whenever the bacterial virulence increases or the host immunity decreases, the infection occurs, and the infection is defined as inflammatory response of the urothelium to bacterial invasion. So the basic pathogenesis of UTI in women is the bacteria enter from the vaginal and the gut flora into the bladder, and there they may be inactivated by the acidic pH and increased osmolality, and once they are inactivated they may be flushed out in the next void. But the remaining bacteria again may be inactivated by the local host defenses, which are Tom horsfall protein or IgA antibody, which bind to the bacterial fimbriae and make them inactive so that they don't adhere to the urothelium. So the bacteria which evade these local host defenses enter the urothelial cells and start multiplying within the cells to form biofilms. Once they are within the cells, they are immune to any of the host defenses and may stay there for decades together and trigger an inflammatory response whenever the host defense goes down. And once from here they can ascend into the kidney, causing pyelonephritis, and enter the bloodstream through the glomerular capillaries, causing bacteremia or septicemia. Coming to the definitions, isolated UTI is when the patient first gets the first episode of infection is called isolated UTI. It may be resolved with antibiotics, or sometimes it may remain unresolved because of the bacterial resistance, or sometimes the infection may be caused by more than one strain of bacteria. One strain may be sensitive to the antibiotic which we have chosen, and one may be resistant. Sometimes the bacteria develop resistance during the course of the treatment, or sometimes the minimum inhibitory concentrations may not be achieved in the urine because of azotemia. Then comes the recurrent UTI. The recurrent UTI is again of two types. It could be reinfection after the initial episode is completely cleared because of the mechanism of again the ascending infection from the either vagina or the anal canal, or sometimes it is persistent bacteriuria. So the initial episode is never cleared because of some persistent source of infection like a staghorn caliculus. And there are some more definitions which we would like to know, like asymptomatic bacteriuria is isolation of specific quantities of bacteria, which is usually labeled as more than 10 to the power of 5 colony forming units per ml from an appropriately collected urine sample. For example, in a woman it should be clean catch midstream sample in the absence of symptoms of urinary tract. Acute uncomplicated urinary tract infection is symptomatic bladder infection characterized by frequency, urgency, dysuria in a healthy woman with normal urinary tract. So, infections, UTI can be classified as uncomplicated when it happens in a normal urinary tract, normal in the sense it should be normal anatomically as well as functionally, in a healthy host. Complicated UTI is infection in an abnormal urinary tract in an immunocompromised host, and it is caused by resistant bacteria. Some of the examples of complicated UTI are when it happens in a functional or anatomically abnormal urinary tract. The functional abnormality, it could be a neurogenic bladder, or infections in men, infections in children, infections in elderly individuals, or in diabetics, in pregnancy, or a hospital-acquired infection. which is usually, multi-drug resistant, as you all know, or infections associated with indwelling catheter, or if a patient has a recent antimicrobial usage, that means we expect those bacteria to be, the infection to be caused by a resistant bacteria. So what are the risk factors associated with uncomplicated UTI? Usually in the younger age, like, premenopausal reproductive age group, the sexual intercourse is a triggering factor for infections in this age group. Spermicidal creams, by destroying the vaginal lactobacilli, increase the uropathogenic bacteria in the vaginal flora, which can then ascend into the urinary tract to cause urinary infections. Family history of UTI is also a risk factor for infections in uncomplicated UTI. Probably by this may affect their IgI status, which acts as a local defense to prevent urinary infections, as I just discussed. Our history of previous UTI is another risk factor, as we have again seen. Recurrence is very common. Once a patient suffers from UTI, there's almost 25 to 50% chance that she would get another infection. Clinical presentation of uncomplicated urinary tract infection, as you all know, it could be asymptomatic bacteriuria, as we just discussed. We isolate a significant number of bacteria in the absence of symptoms. It could be acute cystitis or it could be acute pyelonephritis. Diagnosis and management of uncomplicated UTI, we'll first talk about this. You all know the symptoms: frequency, urgency, dysuria, hematuria, or suprapubic pain. So in a woman, if both dysuria and urgency are present in the absence of vaginal discharge or irritation, almost 90% of the times it is urinary tract infection. So just based on the history, a focused history, you can diagnose urinary infection clinically. Dipstick method to look for nitrates and leukocyte esterase is also a way of diagnosing uncomplicated UTI, but the evidence for this is weak. On the other hand, if on microscopy you find bacteriuria, pyuria, and hematuria, there's a high probability that this could be urinary tract infection. Especially pyuria has a high sensitivity, but the specificity is low, because you all know there is what is known as sterile pyuria. Could be because of tuberculosis, which is common in this country, but there are other reasons for sterile pyuria, like a foreign body like stent or an indwelling catheter or calculus or interstitial cystitis. So pyuria per se doesn't mean infection. If, on the other hand, if there is bacteriuria in the presence of pyuria, there is a high probability of urinary tract infection. So according to EAU, European Association of Urology, the diagnosis of uncomplicated cystitis, there's a strong recommendation to focus on the history. If the focused history, as I just discussed, according to, if the patient presents with frequency, urgency, dysuria in the absence of vaginal discharge, there's a strong recommendation that this should be diagnosed clinically as urinary tract infection. And dipstick test for looking for nitrates or leukocyte esterase is only a weak recommendation, but it is still used for screening. Urine culture is not required in every patient with suspected uncomplicated lower urinary tract infection. It's recommended only when we suspect acute pyelonephritis, or if the patient presents with atypical symptoms. Probably patient has frequency, urgency, suprapubic pain, but no dysuria. We don't know what it is, so that's the time we have to do cultures. Or if the patient is not responding to appropriate antibiotic treatment, or if there is recurrence after treating the infection, we need to do cultures. And pregnancy is an indication to do culture. There, even if we suspect infection strongly, whether asymptomatic bacteriuria or clinical UTI, we have to do cultures to choose an appropriate antibiotic. So urine culture and imaging, ultrasound or CT, are recommended only when we suspect acute pyelonephritis, or in the presence of, or when we suspect complicated UTI, especially pregnancy. Management of uncomplicated cystitis, the drug of choice, the first line treatment is either fosfomycin or nitrofurantoin. Fosfomycin, a single dose, you all know. Nitrofurantoin, at least for 5 days, 100 milligrams twice daily. Alternative to the first line treatment, if these drugs cannot be given, like fosfomycin sensitivity or first trimester of pregnancy where you can't give nitrofurantoin, cephalosporins is an alternative. You prescribe cotrimoxazole only if you know the local resistance patterns, and if the E. coli resistance in the local community is less than 20%, then only you prescribe cotrimoxazole. So it's just a flow chart. You just give a 3-day course or single dose therapy when you have a patient with uncomplicated bacterial cystitis in a non-pregnant woman. And then repeat the cultures again after a couple of weeks. And if there is no infection, patient doesn't require any further imaging or screening. But if there is a repeat culture showing bacteriuria, look at the organism. If it's the same organism, it's probably persistent bacteriuria. That means there is some source in the urinary tract. So do a imaging, either ultrasound or if required a CT scan. But if it is a different organism, new organism, that again indicates it's a reinfection. Again, another ascending infection from the anal canal or vagina. So again, these patients do not require any imaging. So recurrent urinary tract infections, Dr. Soumya has already gave the definition, either 2 episodes in the last 6 months or 3 episodes in 1 year. So what are the risk factors for recurrent UTI? They're different for different age groups. For premenopausal women, it could be, as I said, the sexual intercourse is trigger. Use of spermicide, which destroys the vaginal lactobacilli and predisposes these women to uropathogenic E. coli infections. A new sexual partner, mother with a history of UTI, as I said, possibly because of lower levels of secretory IgA antibody in the urinary tract, or history of UTI during childhood. In the postmenopausal and elderly woman, again, history of UTI before menopause is a risk factor for them to develop infection in the older age group. And estrogen deficiency. What does it cause? Estrogen deficiency decreases the glycogen content in the vaginal epithelial cells. So the acidity is decreased. That means the pH of the vagina increases. There is decrease in the number of lactobacilli and increase in uropathogenic E. coli. So that is a mechanism how the estrogen deficiency predisposes these postmenopausal women to recurrent UTI. Or sometimes it could be a pelvic organ prolapse or cystocele leading to significant residual urines. Catheterization or institutionalization, hospitalization, any other pelvic surgery also increase their predisposition for recurrent urinary infections in the postmenopausal age group. So risk of recurrence, again, Dr. Soumya Mandal has just mentioned, 46% of the women develop recurrence within the first year of the initial episode. The risk of recurrence is about 26% if there is one previous episode. It can go up to 85% if there are two or more episodes. So that means the risk of reinfection increases with the number of previous episodes and decreases with the time gap between the first and second infection. So how do you evaluate these women with recurrent UTI? So every recurrence has to be confirmed by a culture. You just can't go by their symptoms and label it as, just because the patient complains of dysuria, especially in the elderly age group with atrophic vaginitis, dysuria is a very common symptom. Don't treat every dysuria with antibiotics. So it has to be confirmed by culture. Significant counts in the absence of pyuria is again not urinary infection. Most of the times, especially in women, it is contamination. So if there is bacteriuria in the absence of pyuria, again don't give antibiotics. If at all you have any doubt, if the patient has clinical symptoms, repeat culture with proper collection. Imaging is required in these women to rule out any calculus or any outlet obstruction which may predispose to infection. And more important before any of these investigations is proper examination. in young children. I will just tell you one example. I had a patient long time ago, 2-year-old girl with recurrent UTI being treated by city's most prominent or most eminent urologist. That girl was a granddaughter of another eminent orthopedic surgeon in our city. So for the last 6 months to 1 year, she's been getting repeated infections. Finally, the doctor had brought her to me, and an examination, that girl had labial adhesions. So just because we haven't examined, we shouldn't be, examination is part and parcel of, even if it is UTI, even if you have proved a culture, don't give antibiotics repeatedly. Look for some cause, underlying cause, especially if it is a recurrent UTI. So these labial adhesions are very common in pre-pubertal age group and postmenopausal women because of estrogen deficiency. So once those adhesions were released, the girl was free of recurrent episodes. Also look for pelvic organ prolapse, cystocele, which may cause significant residual urine and predispose the woman to recurrent infections. And genitourinary syndrome of menopause, patient can present with dysuria, patient can also have recurrent UTI. So as I discussed, the reason is estrogen deficiency, which increases the uropathogenic E. coli colonization in the vagina, which ascend into the urinary tract. So the summary of evidence and recommendations for diagnostic evaluation and treatment of recurrent UTIs, again according to European Association of Urology. So every recurrent infection should be diagnosed by urine culture. There is a strong recommendation for this. Do not perform extensive routine workup like cystoscopy, whole abdomen ultrasound in a woman, younger woman, less than 40 years of age, in the absence of risk factors for complicated UTI. This doesn't apply to all women with recurrent UTI. If it's elderly woman, we need to screen. If she's pregnant, we need to screen. So why we are saying this is not required extensive investigation? In this age group, in the absence of risk factors, most of the times it is reinfection. In a healthy woman, normal urinary tract, it is reinfection. So extensive workup is not indicated. Again, you have to use your clinical acumen and individualize the case. Advise patients on behavioral modification. Though the recommendation for this is weak, I strongly recommend this because of my clinical experience. I see women who get recurrent infections, we have to actually ask them their water intake, their bladder habits, especially postponing voiding is one of the predisposing factor for infection. As I said, bacteria continuously enter the bladder, so we have to flush them out periodically so that the bacteria don't settle in the bladder and don't invade the urothelium. So I have seen in my practice, especially women come back with the urinary tract infection after they travel. The two things which happen in the Indian scenario, since we all know it's a social problem, we don't find any good restrooms on highways or wherever we visit. So women tend to drink less water and tend to postpone the need to pass urine. So these two factors trigger their infection whenever they travel. But most of the patients, they are under the impression that, under the misconception that by using public toilets they caught infection, which as urologists you all know, it doesn't give they don't catch infection by using a public toilet. It's the other way around, by postponing the need to pass urine and by drinking less water. They are the triggering factors. Other behavioral modification are change of contraception from spermicide to let them move on to some barrier contraception. Also, managing constipation. Constipation is another risk factor for recurrent UTI because again the uropathogenic bacteria are loaded in the anal canal and perineum. They ascend into the urinary tract. In postmenopausal patients, there is a strong recommendation to use vaginal estrogen if the woman is suffering from recurrent UTI, as we have already discussed how the estrogen helps. Immunoprophylaxis, either oral or sublingual, parenteral, the different forms of vaccines have been developed. But earlier, the recommendation was strong to use immunoprophylaxis for all patients with recurrent UTI, but now it's downgraded to a weak recommendation. And once we have tried all the non-antibiotic prophylaxis, let's now move on to the antibiotic prophylaxis. It could be long-term low dose. We all know for recurrent UTI we give low dose long-term antibiotic prophylaxis, or it could be intermittent prophylaxis, either postcoital prophylaxis if the infection is clearly related to the intercourse, or it could be self-start intermittent therapy. If it is a random infection but the patient is well educated, we can counsel her to identify or recognize the symptoms of UTI, and instead of she visiting the urologist or a hospital every time, she can recognize the symptoms and start a short course of antibiotics, but we need to monitor these patients periodically. So the flow chart again, if a patient with recurrent UTI, treat the infection with a single dose or a 3-day course of antibiotic, and then if it's a premenopausal, behavioral therapy, if it's postmenopausal, give them estrogen, and then put them on either long-term continuous antibiotic prophylaxis or intermittent, either postcoital or self-start intermittent therapy. So this patient, one case scenario, a 62-year-old woman with recurrent UTI, she underwent abdominal hysterectomy 10 years ago. Just look at this. So I did a cystoscopy because even her ultrasound was normal. She was not getting any relief. There was almost persistent bacteriuria, and cystoscopy, that is what it has revealed. Vertical limb of the copperty. I tried, with lot of effort, I couldn't take it out. And then I did an X-ray to see how it is positioned, and then CT. That's how it is, the vertical limb in the lumen, the horizontal limb on the outer surface of the bladder. So we were really intrigued to know how the copperty has entered the bladder in a postmenopausal woman who underwent hysterectomy 10 years ago. Probably this lady had forgotten about her copperty, and during abdominal hysterectomy, this must have slipped from her uterine cavity into the abdominal cavity and slowly found its way into the bladder. So again, cystoscopy is not indicated in every woman with recurrent UTI, but you have to again use your clinical acumen. In a younger age group, probably no, where there are no risk factors, but in this age, and if the patient is not responding, we have to look for other causes. So this is another very important topic, urinary tract infection in pregnancy. Again, the prevalence is high, almost 31%, and we all know it increases the perinatal morbidity and mortality, and also maternal morbidity. 40% of the infections are diagnosed in the first trimester. So the US Preventive Services Task Force recommends that we have to do a urine analysis and culture in every woman at the time of, every pregnant woman at the time of first visit itself. Almost 90% of the acute pyelonephritis in pregnancy occur in the second and third trimester, and mostly due to progression of untreated lower urinary tract infection. So again, even if the first culture is negative, repeat cultures in the second and third trimester to detect asymptomatic bacteriuria so that we treat them and prevent the onset of pyelonephritis. But why UTI is common in pregnancy? Because of the growing uterus compressing the bladder may cause significant residual urines, ureteral stasis, again because of mechanical or hormonal causes, glycosuria and amino aciduria, and increased pH or decreased acidity and decreased osmolality, which are the natural defense, host defenses to prevent lower tract colonization, which may be altered in pregnancy, and also immunomodulation, which makes these women more prone for any infection. So this UTI during pregnancy can be again of 3 types: asymptomatic bacteriuria, cystitis or pyelonephritis. Asymptomatic bacteriuria, if untreated, can lead to cystitis, clinical lower tract infection in almost 40% of the women, and risk of pyelonephritis in about 30% if untreated. Cystitis is seen in about 2% of the pregnant women, but Initially, the symptoms may be confused with pregnancy-related symptoms like frequency, urgency, suprapubic discomfort. They are all seen even in the first trimester of pregnancy, so it may be missed out if we don't screen them for bacteriuria. And undetected and untreated cystitis can lead to pyelonephritis in almost up to 50% of the patients. Acute pyelonephritis again is the most serious complication of urinary tract infection during pregnancy. The overall prevalence is about 1%, but if a woman has asymptomatic bacteriuria which is untreated, the prevalence can go up to 28%. So again, it stresses the importance of screening the woman for asymptomatic bacteriuria. And once a woman has pyelonephritis during pregnancy, after we treat it, the risk of recurrence is almost 23%. So what are the maternal complications with acute pyelonephritis? Increased risk of maternal anemia, increased risk of preeclampsia. You all know the morbidity of these two conditions, anemia and preeclampsia in pregnancy. Urosepsis, which can increase the maternal morbidity and even increase the mortality. Perinatal morbidity and mortality are also high because of premature rupture of membranes or because of preterm labor, low birth weight. Mental retardation can be seen in neonates because of either bacterial endotoxins or cerebral hypoperfusion. So there are so many complications which can occur both maternal and perinatal due to untreated pyelonephritis or untreated urinary tract infection. So again, the flow chart is single dose or short-term 3-day course is not enough to treat a urinary tract infection during pregnancy. A complete 7-day course of antibiotics is what is recommended, and repeat cultures after 2 weeks. If the culture is again positive, then we have to put them on low-dose suppressant therapy for 4 to 6 weeks postpartum, throughout pregnancy and for up to 6 weeks postpartum, and this lady would require imaging of the urinary tract. If this repeat culture is sterile, she doesn't need any further treatment, but we have to repeat screening for bacteriuria at every visit. The antibiotic regimens which are usually recommended during pregnancy are cephalexin, as you all know, 500 milligrams 6 hourly. Phosphomycin single dose is enough. Nitrofurantoin is safe except in the first trimester. Cotrimoxazole can be recommended only in the second trimester, not in first or third trimesters. The antibiotics which are contraindicated during pregnancy are tetracyclines, aminoglycosides, fluoroquinolones, and trimethoprim in the first and third trimester, nitrofurantoin in the first trimester. I don't need to tell you the management of pyelonephritis. If the third generation cephalosporins are the drug of choice, but if it is ESBL Enterobacter, then carbapenems are safe in pregnancy. But if the patient is not responding to medical management, we may have to do a urological intervention in the form of stenting, especially if the patient has hydronephrosis or signs of pyelonephrosis. If in the rare instance where the stent cannot be passed, then ultrasound guided PCN may have to be done to relieve the obstruction, to decompress the infected system in order to save a patient's life. I'll again share with you one more experience. This is a 24-year-old woman, 28 weeks pregnancy. She is brought to our hospital, admitted in the medical ICU under the care of primary physician. She had been having fever and on parenteral antibiotics for 3 days prior to admission in our hospital. I was called for a urology consult. She was hemodynamically stable, but her counts were elevated and she had acute renal angle tenderness, and the ultrasound was this, there is hydronephrosis, and I immediately suggested stenting, but the treating physician wanted to change the antibiotic to carbapenems and observe. The next day, again, I went and saw and again advised stenting, but this time the physician was happy that her counts are decreasing, so he wanted to observe for some more time. The 48 hours after I saw the patient, she was shifted to a urology OT for emergency stenting, and she was in a very bad shape. No pulse and BP were to be recorded, and fortunately I could pass a stent under local anesthesia. And believe me, within few hours after stenting, she became hemodynamically stable, and by the next day she could be shifted out of the ICU. So prompt intervention in these cases, especially in pregnancy, may be life-saving. So don't delay your intervention when indicated. And antibiotic prophylaxis in pregnancy, if the patient has 2 episodes of cystitis or even 1 episode of pyelonephritis, give her low-dose antibiotic throughout pregnancy and for 6 weeks postpartum. The non-antibiotic prophylaxis is very important in the Indian scenario to prevent the emergence of bacterial resistance. So what are the various ways we can prevent infections without using antibiotics? As we discussed, behavioral therapy, like drinking enough water, voiding at recommended intervals, not to postpone the voiding, and change of contraceptive from spermicide to barrier contraception, and managing constipation, which is very important. Cranberry and D-mannose have a weak recommendation, but if you look at this picture, in vitro studies, the cranberry, the pre-anthocyanidin A, that decreases the biofilm formation. You can see from this, as the cranberry concentration in the cultures have increased, the biofilm density, you can see there are hardly any bacteria here. So I don't know how much it is useful in the real life scenario, but I still use cranberry in uncomplicated lower tract infection in women without risk factors for complicated UTI. Probiotics again are very useful because the advantage is there is no risk of emergence of resistant strains, and they are almost 80% of the cases the reinfections are prevented, especially in elderly postmenopausal women along with estrogen. When you don't want to give, this will reduce the adverse effects related to antibiotics. So probiotics have a role in preventing recurrent infections. Local estrogens we have discussed. Estrogen replacement in postmenopausal women is always local estrogen to prevent recurrent UTI. It's not the systemic estrogen. So it increases the glycogen content in the vaginal cells, decreases the pH, increased lactobacilli, and decreased uropathogens. Immunoprophylaxis, the different types of vaccines, oral, vaginal, sublingual, parenteral. The evidence doesn't show real efficacy as compared to the placebo, no significant difference. So, which was a previously strong recommendation has now downgraded to weak recommendation according to EAU, but may be beneficial in frail and elderly where you don't want to give antibiotics repeatedly. So the new kid in the block is methenamine hippurate. It's been discussed in detail by Dr. Soumya. I won't go into the further details. So, but I just wanted to mention this trial compared to long-term antibiotic prophylaxis with nitrofurantoin, cephalexin, trimethoprim. The non-inferiority trials have shown almost equal efficacy, and the advantage again is there is no risk of emergence of resistant bacteria. Thank you.
So if there are any question, you can ask. Any question for the madam?
Thank you for an excellent presentation, but
Thank
could you elaborate on what the EAU guidelines talk about phytotherapeutics in UTI? It seems, we are more into using cranberry and
Yeah.
D-mannose and probiotics.
And
there's a strong
hibiscus,
indication for cranberries, and are such products available in our country? Or there just seems
We
to be
only
a level
have-
1A recommendation in the EAU guidelines.
Yeah, we only have the cranberry, D-mannose, and hibiscus combination, not the other phyto products.
Okay, and would you elaborate on the use of vaginal estrogens
Yes.
in perimenopausal women and the side effects of vaginal estrogens, is it really contraindicated in patients with breast cancer?
No.
Or, I mean, if the patient asks you, you know, there's a
Yes,
lot of
yes.
thing,
Yeah.
well-informed patients will ask you
Sure.
and tell you.
Yeah. So vaginal estrogens, we have two types, estriol or conjugated estrogen. We use it, the induction therapy is once a daily dose for almost 2 weeks, followed by twice a week for 3 to 6 months, or as long as the patient finds benefit from it. And as you asked rightly, so we have some reservation about using it in patients with past history of breast cancer or family history of breast cancer, but there is no evidence to prove that local vaginal estrogens are carcinogenic. But there is some reservation in using it definitely, but in my patients with family history of breast cancer, I always advise them to get a mammogram before I put them on estrogen, especially long term.
Good evening.
No, no. They're not useful, not effective for UTI.
Good evening, ma'am. Nice and wonderful presentation. Most of the patients who have recurrent UTI, they usually ask whether to go for a vaginal wash or that type of substances which the gynecologist recommend. How do you consider this
Actually,
question?
we tell them not to use any vaginal douches. They would actually destroy the immunity the patient already has. Vagina is naturally healthy. It has low pH, high lactobacilli, and these douches only damage the native lactobacilli and may increase the risk of UTI.
Okay. Thank you, ma'am.
Vaginal cream in non-hair area to get the same effect as local application of vagina, local application estrogen in vagina.
I didn't
No,
understand.
no. Can you apply vaginal cream, that's primary cream like that, in
Yeah.
non-hair area with same effect in when applying in vagina with of estrogen? No,
Vaginal
I'm
cream
asking.
applied where? I didn't
No,
understand.
I am asking that can I apply this vaginal cream in non-hairy area to have the same
Non-
effect, hairy area?
Vaginal cream
Just
is
like a
applied in the
testosterone,
vagina.
just like testosterone we apply on a non-hairy area to have,
Oh, on the skin you mean to say?
yeah, yeah.
It may not be absorbed. It's meant to be used only for vagina.
Okay, thank you, ma'am, for your excellent presentation. I really appreciate your time and effort. Now, our next speaker, Professor Devanshu Sarkar. Sir, kindly come to the dais.
Good evening, my teachers. Good evening, ma'am. Thank you, BUS, for inviting me here. Today morning only, I was asking questions to my students. Today morning, very basic questions on UTI, and you will be surprised to know many of the questions got unanswered. I'm sure that if I would have asked them questions on CA prostate, anything on CA prostate, they'll be very happy to answer. This is a real scenario. This is the reality. All of us think that we know everything about UTI, but the thing is we do not know probably most of UTI. Let us accept this. Okay, let us accept this and start. So from this, there is a symposium this year, UCCon Indore, as part of the speakers, and the recurrent UTI nomen and what are the evidences and what are the unmet needs. And based on this, there is a question that do you need more evidence to form evidence-based guidelines? Why this question was raised? Because actually there is no guidelines in Indian scenario. There is no guidelines from this subcontinent. What guidelines I could find out in English literature is only EAU and AUA guidelines. And if you have noticed ma'am's presentation, there is many guidelines which are showing recommendation. What is a recommendation? Some showing strong recommendations, some showing very weak recommendations, some saying moderate recommendations. That means the evidence on which these guidelines are based, more than 50% cases is weak. What does it mean? If you go retrospectively, that means there is not enough studies which is done on UTI. Let us accept this. So that is the reason we have this weak recommendation, moderate recommendation, all these things. For the youngsters, what is the clinical guideline? It's basically a pathway. We should treat a disease, any disease. Guidelines can be on, say, prostate, RCC, UTI, anything. So that is a pathway made by a body of specialists based on some clinical evidence. That is the guidelines. So how it is formed? It is first, let us take, if we want to form a guidelines on UTI, so we need to know what are the things we do not know, or we know but it is not based on evidence. So we have a key questions. Based on this, we want to know the answers. What are the answers? So based on these key questions and what are the answers we are expecting, the basic formulation of guidelines starts. So how to form some evidences? You look for what are the literatures in the print media or electronic media. So you look for meta-analysis, you look RCTs, you look for case reports, everything. And after you got these evidences in the form of RCTs or meta-analysis of RCTs or case reports or expert opinion, these are given some strengths. See, a study which is very well formulated will be given a very strong strength compared to expert opinion. So the level of strength is given from 1 to 5. If you go from 5 to 1, the strength of evidence increases. What does it mean? That means if you have, you can see here, if you have a strength of A, that means that the probability that if you do this study again and again on 100 patients will be the same if you have a very strong evidence, versus if you have very weak evidence, that means the probability of having the same result on all patients is not going to same. This is certainty basically. So based on this evidence, strength of evidences, we find a recommendation. Recommendation means you should do this, you should not do this, you may do this, you may do this on certain situations. These are the recommendations. So based on this, if you see that there can be strong recommendations, moderate recommendations, conditional recommendations in certain situations. Sometimes it can be clinical practice or expert opinion. For these last two, mostly there are no good evidences. These are from clinical experts. So if you have a strong recommendation based on evidence strength A, I have enough studies on that question. So if I recommend something, I know any future studies on this is not going to change the recommendation. So I do not need any further studies on this. So this strong recommendation is based on evidence strength A. But if I form a strong recommendation based on evidence strength C, that means I have made a strong recommendation for some reason, but I know if in future I have better studies, this recommendation is likely to be changed. So let us, based on this, let us see what are the evidences which is there. As Madam was showing, many used recommendations, many of them were weak recommendations. Let us find which of the recommendations has a strong recommendation based on grade A evidence, which are the recommendations, which are clinical expert opinion or clinical principles. Let us start from the evaluation of UTI. As Madam was saying, clinician should obtain a complete patient history and perform a pelvic examination in women present with UTIs. Even this basic diagnosis is based on a clinical principle. It is not based on any, it is a strong recommendation, but it is based on clinical principles. That means there is no good RCT based on which this recommendation was based. So you need to have studies on this, starting from the evaluation only. Okay, let's go to the second point, urine analysis, urine culture and sensitivity. This is also based on a grade C. I'll come why this is a grade C recommendation. Cystoscopy and upper tract imaging, that means doing some more investigation in patients who has acute cystitis in acute cystitis episodes in recurrent UTI should not be done. This is also an expert opinion. That means there is no good, strong evidence to support this. Let's see why this is a strong grade C recommendation. So how to define a UTI? How to define a UTI? So this is an interesting meta-analysis of 47 studies. You can see the basic definition of UTI was different in most of the studies of these 47 studies. So if you cannot define the population, if you cannot define what is UTI, how can you expect a uniform result out of these 47 studies? The first thing you should do, we should have a unanimous decision to define what is UTI. That is lacking. So you can imagine where do you stand regarding UTI. Okay. Next is if you do a urine CS, what is significant bacteriuria? Some will say it is 10 to the power 5. Some will say for MSU symptomatic it is 10 to the power 2. Some will say if you do a catheterized sensitization it is 10 to the power 4. So different groups, different studies, the level or the colony forming unit threshold is different. This is not uniform. So you cannot form a recommendation or justification based on non-uniform studies. That is happening in UTI. This is unfortunate. There is a study, the standard urine culture reassessing the characteristics of a criteria standing for detecting urinary microbes. This you can see 2023 in Journal of Urology. They concluded after this meta-analysis of multiple randomized studies, urine culture is not good for detecting UTI. It is good for negating UTI. If a patient, if you think the ma'am was saying, elderly patients, recurrent UTI, you are confused, this patient has asymptomatic bacteria with vaginitis or urethritis, or this patient has actually a acute cystitis on a background of recurrent UTI. How to differentiate? You need to do a urine culture. The thing is, if you solely depend on urine culture, 40% cases will miss. But on the contrary, if you do not find the patient is having a positive urine culture, you can say this patient is not having UTI. So the importance of UTI, urine culture in a patient with suspected acute cystitis is not on diagnosis, is on telling this patient is not having UTI. Okay, but we think reverse. This is also dubious, the association between pyorrhea and urinary infections. There is actually no association. What about other non-microbiological diagnostics? These are more sensitive, but the problem is this will pick up more patients who are actually not having UTI, who are having bacteria. So the current status of this non-microbiological diagnosis, genetic testing, is not standardized. We need more studies on this. Asymptomatic bacteria, whether you should, is a very frequent scenario in all of our practice that elderly lady, 72 years, post-menopausal, comes with a urine culture in your clinic. She was treated with 2 antibiotics 1 month back, 1 antibiotic 3 months back. Now again she has done a surveillance urine culture. She has some dysuria. What to do? Whether the patient is having acute cystitis or this is asymptomatic bacteria. So you need to have some guidelines. See, the evidence grade is C. It's not A or B because we do not have studies, adequate studies. And this is not my study. This is AUA and EUA recommendation. Clinician should not treat asymptomatic bacteria. At least we have a grade B recommendation, strong recommendation based on evidence B. Should we treat asymptomatic bacteria before surgical procedures? So we have guidelines for if the patient is posted for trus biopsy, if the patient is posted for TURP or TURBT or urological procedures. Many patients, you will get reference from the orthopedic surgeon, the patient is having a recurrent positive urine culture, I'm not saying she or he is having, she is having UTI, recurrent positive urine culture, she is posted for TKR. But because of recurrent positive urine culture, she is deferred for surgery. What to do? Should we treat the patient? Should we not treat the patient? Should we cancel? Many times I have a categorically written, it's not written. But even after that, the orthopedician is not ready. Because in their books, it is written there should not be an infective source in the body before any replacement, joint replacement. So the recommendation of the strength of evidence in our book also, it's not A, it's a grade C recommendation. So on that strength, we cannot be very dogmatic that yes, nothing will happen to you, you can go for a TKR. That is a problem. We do not know what we should do if we are planning for a CTVS surgery, CABG or a valve replacement. The patient is having a positive urine culture. We do not know. But these are the clinical situations we need to study because this is a very, very common practice. All of us, the more senior you become, the more referrals will get on these pictures. We do not know the answer because there is no studies. Antibiotic treatment, fortunate enough, we have a consensus what is the first line you should give on acute cystitis. That is good enough. What if the common scenario, patient comes with history of recurrent suspected UTIs, recurrent antibiotic uses. Now the patient comes with a Klebsiella pneumonia, which is resistant to everything except intermediate sensitive to cholesterol. I am sure that all of us has faced this situation. What to do in this patient? Patient is not symptomatic. So we need more studies on this also. This is an expert opinion. We can go for IV antibiotics, but no studies. The basic questions, do we need antibiotics in all UTIs? What happens to the patient who comes from a remote village, who do not have easy access to doctors? What happens? The same UTI happens to them also. What happens? They do not get treatment. Do they get febrile UTI? Do they get pyelonephritis? Do they die? No. So there is few studies who show that if you do not treat patients who are having acute cystitis, at least 25 to 30% patients will resolve their symptoms without any treatment. Nothing. You do not do anything. 20% patients, 28% patients will be cured of their disease. So the basic questions comes, in a patient of recurrent UTI with suspected acute cystitis, do you need to treat the patient? There are studies which shows probably no. Probably you should not treat all patients. But obviously, yes, the patient is immunocompromised, he is subjected, he is posted for some surgeries, yes. Otherwise, 100% patients do not need treatment. Even treatment with ibuprofen might help some patients instead of antibiotics. More than 1/3 of patients will be symptomatic relief. Because our aim of treating UTI is not to eradicate the bacteria. It's not practically possible. Postmenopausal lady with recurrent UTI, so-called UTI, our aim is not to eradicate the bacteria. Bacteria will be there. Aim is to give symptomatic relief. So why to give antibiotics if it is not eradicated? Our aim is not eradication. So you can give ibuprofen. In fact, you may not give anything. You can give the potassium citrate or paracetamols, plenty of waters. That we need to know, that we need to work upon. There is a recommendation, EOE recommendation, evidence with 1A. Antibiotic prophylaxis, yes, the patient who has recurrent, ma'am was saying, this is a conditional recommendation. That means you need to discuss with the patients, you need to take the patient as a whole. What are the other comorbidities? What are the patient's bowel habits? Any other foreign elements like copper T the patient has, neurogenic bladder? Then you categorize the patients, and after that, conditionally you can put the patient on antibiotic prophylaxis, not routinely. It's a grade C recommendation. Which is not known is which antibiotics, what is the schedule? Is it a continuous Or is it a as and when needed, just like postcoital prophylaxis? We do not know. There is a lot of ambiguity on this also. And what is the duration? If I ask these questions to all of the seniors sitting here, I am sure that I'll get 5 or 6 types of answers. Somebody will give 3 months, some will give 6 months, some will give SOS. What is the evidence? What is the antibiotic which we should give, in which dose, how and how long? It's not known. We all have our own regimes. Non-antibiotic prophylaxis, ma'am already told, estrogen. How to follow up this patient? The patient had recurrent UTI, you have treated the patient, how to follow up? Do you need a post-treatment urine culture? This is an expert opinion, but fortunately most of us do not do follow-up urine culture in patients, in these patients. But if the patient has recurrent symptoms before treatment, you have to do a repeat urine culture just to decide whether this is a repeat infection or this is a persistent infection. If you have a persistent infection, yes, you need to investigate what is the reason for persistence. Otherwise, if it's a repeat infection, it's not needed. So we have scopes of evidence acquisition. We need to define UTI. We need to define what should be the microbiological threshold to call it an UTI instead of asymptomatic bacteria with other things. We need to study on non-antimicrobial agents. We need to study how to treat ABU before surgical interventions and how to follow up. Thank you. I'd like to have questions from the seniors only, because you have a lot of experience. You started much before me. So what is your thought on recurrent UTI? This is a very burning issue. We do not think about recurrent UTI.
What is the difference between recurrent and reinfection?
Sir, you are late. Ma'am has already explained this. I will not give this answer.
Because
Rec-
most of them, they don't differentiate between the recurrent and reinfection because these are two different entities.
Yes, I do agree with you. That's why I was telling. Reinfection and recurrent infection is different. The investigations for both this is different. The treatment for both is different. So all of us, we need to have a clear idea why the patient has reinfection versus why the patient is having recurrent infection, because the treatment is different.
Because one is the same, if the bacteria is the same, it is reinfection. But recurrent may be
Yes,
other bacteria.
I agree,
It
sir.
is not the same bacteria. That is the main difference.
Yes.
It is not the. What are the causes of recurrent infection in postmenopausal women? Why? They are more prone to recurrent infection.
Yes. There are many factors. Some of them are constipated, some of them are diabetic, some of them have voiding difficulties, some of them have metal stenosis. All of them are devoid of estrogen, so the local uh, immunity is less. These are the factors. Some of them will have a prolapse also. So any patient, particularly elderly ladies who comes with recurrent infection, we need to rule out any anatomical cause or functional cause. Why this patient is having recurrent UTI?
What is the actually main sort of cause? In my practice, what I think, it is the residual and post-void residual urine is the main cause of recurrent infection in postmodern women. Due to estrogen deficiency, there is submucosal fibrosis, and the bladder cannot empty. Even a 15 ml residual urine can cause reinfection. Another is because this vagina and rectum is very close, the organisms, they move directly into the bladder. Small urethra, it is inside the vagina. So bacteria goes into the side, and if the bladder does not empty completely, there will be residual and there will be recurrent infection. Those are the, I think that is my, and another what I have observed in my 42 years practice, the rural and urban practice. Because the introduction of bacteria from rectum to bladder, there are three ways. One is the bacteria can move. These are motile organs, most of them. Second is that continuous use of underwear, especially in our country, in summertime, where there is sweating. Because that cloth, when you are sitting, there is to and fro movement of the cloth, and it is from back to front. Another thing. Another thing is in.
We have a discussion, sir. We have a small discussion we can discuss. We are already running late.
Okay. Because because they need all usually submucosal fibrosis, usually meatal cirrhosis, what you have said, that they need cystoscopy and urethral dilatation. You will see the obstructive changes and dilate it and put them on hormone replacement.
Yes, sir. Madam has
Thank you, sir. Thank
definitely
you, huh.
done to it. Thank you, sir.
Sir, Sir was telling something. Kullan, sir?
No, just a comment on, you see, you made a very excellent presentation on guidelines and the role and practice. But I think guidelines are guidelines, and I think you cannot have evidence base for everything. Like all the comments Dr. Pradhan means, it will be a hell of a lot too difficult, a lot of effort to prove by randomized trial that whether you wipe from front to back or back to front. So there must be some common sense in our approach. And in India, you also mentioned at the outset that there's the two guidelines only. Yes, there are two guidelines, but in India, again, we have to be very sensible, and there's a type of medicine you practice in a center of excellence in a government institution. There are other doctors who are practicing in a very rural area, or other doctors who are practicing in a different area of practice. So I don't think you can apply guidelines to all sets of patients in India. So there's different types of practice for different types of patient subsets. Man in the rural area, as you said, UTI, recurrent UTI, Klebsiella maybe, they don't die. So, but these are very difficult. So you have to be, you have to have a lot of common sense. One problem which I think none of the, if Dr. Lalita would elaborate or you would elaborate on what the microbiome has to do with recurrent UTIs. Probably isn't that the most important thing, that the bacterial load in the intestinal flora, that enters, as Dr. Pradhan said, proximity of the genital and the rectal passages, urethral and the rectal passages. So it's really the bacterial load of the intestine, and what the microbiome has to pay. Maybe the prevention of recurrent UTIs depends on how you control your microbiome. So, again, there are no guidelines on that, but
So,
maybe you can elaborate.
Yes, sir. Actually, constipation is one of the predisposing factors for recurrent UTI. That is because of the, bacterial colonization and the fecal bacteria entering the bladder. And another risk factor for, infection by resistant bacteria is recent antimicrobial use. So that is altering the gut microbiota
Absolutely.
again.
These are
so
very important.
vaginal microbiota is a reflection of gut microbiota. And these, and from these two places
So
only the
that
bacteria
seems to
enter
be the
bladder.
fundamental thing, and
Yes.
how the E. coli phylum, it adheres to the urothelial mucosa, is fundamental to intracellular bacterial colonization. And that's why your point was well taken there.
And there's
so
one-
these are the fundamental issues in recurrent UTIs. And how estrogens help, Dr. Pradhan, I would differ. It prevents the adhesion of the E. coli phylum to the uroepithelium. Other things are tissue changes are long after.
Estrogen replacement, because after menopause, the estrogen level is very low or little. And the vaginal epithelium, normally when there is estrogen, they produce the glycolysis and produces the acid. That is by Dodderlin bacillus. And when there is no estrogen, there will not be any Dodderlin bacillus. So there is the pH of the vagina is alkaline. That is the cause. So you have to alkaline That is, you need a estrogen replacement and local apply of estrogen cream. These are the very, very important posters. I have given so many thousands of my patients, they are taking estrogen 1 milligram daily. And there is no side effect, no incidence of breast cancer, hardly there is any. No, in that from my experience. What book does not does say that is.
Sir, we have a session, panel discussion. We can discuss it there or over a cup of coffee. Thank you.
I just wanted to mention there's another interesting study which says that vegetarian diet will reduce the risk of recurrent UTI, again probably by altering the gut microbiota.
Okay, thank you, sir, for your in-depth analysis, recommendation, guidelines, and what should know. So, before going to discussion, may I invite Dr. Kollan Sarkar sir to give a token of memento to Dr. K. Lolita madam. Madam, please. ওখানে যাও। Thank you, ma'am. Thank you, sir. May I invite Dr. Tapos Maji, sir, to provide a small token of memento to Dr. Devangshu Sarkar, sir. ছবি তোমার অফিসিয়াল পার্টনার আছে now we are having short time, and by that short time we will have a small panel discussion regarding UTI in female. I would like to invite our extreme panelist, Dr. K. Lolita ma'am, Dr. Kollan Sarkar sir, Dr. Devangshu Sarkar sir, and Dr. Sasikanti Tiwari sir. So please take to the panel chair. বাপরে বাপ, তাড়াতাড়ি হয়ে যাবে, বুঝতে পেরেছো? দেরি করবো না, দেখা এটা খোল।
এই লোকটা আজকে বরাবরই কাটে।
হ্যাঁ, না এখানে করতে হবে। কি করছিস? এটা So most of the topic has been already discussed in detail by sir and madam, and also there is a discussion. So I will have some common OPD or chamber scenario to clear out problem from the expert, and also I have some rapid question to give a rapid answer so that we can conclude it early. So this is a case one of 59-year-old lady came with dysuria and frequency of urine. She had urethral dilatation history in 2011. She underwent transobturator tape 2018 for ACUI. Chronic constipation on medication maintained. No other significant history. Came to OPD at 6 p.m. Most of the CT doctors start OPD in the afternoon rather than the morning. So how to approach, whether to start antibiotic, wait for the culture, or any examination needed at the first visit? Devangshu sir, can you take this question, sir?
History is a little dubious because she had.
This is the only history. There is no other history. Dysuria and frequency, no fever, nothing.
Okay, she had UD followed by TOT. Now she comes to. So I would like to have some investigations or some information from the patient. How was the voiding after this TOT?
Okay, sir.
Was
Okay,
she
sir.
hypercontinent?
She already came with some reports. Patient has already some reports. There shows E. coli. So should we start antibiotic, or what else you want, basically? With this symptom and culture, should we start antibiotic or any other investigation?
See, if she has a frequency along with dysuria and she has a positive urine culture, that means she is having a clinical UTI. So I'd like to have more information whether the patient has asymptomatic bacteria before, whether she was treated with the antibiotics because of UTI before. And since I have a culture report positive and the patient is clinically a case of UTI, yes, this patient needs treatment.
So how long will you give the treatment for the patient had come first time? How long will you give the antibiotics, sir?
That will depend on the urine culture report.
You-
Because if it is sensitive to fosfomycin, I give a single dose of fosfomycin.
Okay, depending on the antibiotic.
Yes.
Okay.
Otherwise, uncomplicated UTI, it's 3 to 5 days. 5 days is maximum.
Is any follow-up needed if you treat the acute episodes, or you
so
don't need follow-up?
that will depend. See, this patient has a history of TOT.
Yes, sir.
So it may not be classified as a simple UTI, acute uncomplicated cystitis. If the patient has any voiding symptoms, if she is hypercontinent, then she becomes, this is not a case of simple acute uncomplicated UTI. Then she will need a follow-up, otherwise not.
Yes. Sir, will you give any other non-antibiotic treatment with the antibiotic always, or depending on the situation or clinical scenario, like in this case?
Non-antibiotic means?
Means like alkalizer, like some flavoxate for dysuria,
See, flavoxate does not work. Alkalizer,
or
yes.
plenty of waters, whatever, the
Yes,
exantic treatment.
Plenty of water she should take. Flavoxate, I don't think it works.
Okay.
Alkalizer, yes. If you find something in the urine pH, it can be added for symptomatic relief. Okay. So if I find this patient has a normal voiding without any voiding history before, then this patient does not need any routine follow-up culture or follow-up. But if the patient gives a history of anything voiding history, then I need to investigate this patient. What is the uroflowmetry? What is the residual urine?
Okay, sir. Patient already got the relief and she lost to follow-up. So again came after 3 months with a similar complaint, dysuria and urine frequency, but milder than the previous symptom. So what next? Should we again start depending on the previous history, or do culture at the evening OPD? What should we give? Or should we consider prophylaxis also in this time? Dr. Tiwari, madam?
You want?
In the first case only,
Yeah.
other symptomatic treatments like constipation needs to be managed.
Yeah.
And since the patient had TOT, uroflowmetry was to be done at that instance only. Post-void residual urine volume has to be examined so that recurrence could have been prevented.
This is the uroflowmetry report. Maybe faint, but Qmax is around 17.6, average is 6.2, and 246.7 voided volume.
But this is an obstructive voiding. You see that there is delay in starting of the urine.
And PVR is only 11 ml.
Okay, that
On
means there is
ultrasound.
almost complete clearance. What is the
And
age
this
of the
time
patient?
again the E. coli, 59 years, again the E. coli, the culture
Okay.
report.
That means there is a recurrent UTI.
Yeah.
Recurrent UTI with somewhat obstructed voiding.
So finding the recurrent UTI, you always want to find what are the reason behind the recurrent UTI.
Yeah.
So is it the constipation, or it is the bladder obstruction due to previous surgery, or what should be the approach in this
At
case?
present, treatment of the second episode and followed by prophylaxis will be a better option for this patient.
What will the duration of
And-
prophylaxis, ma'am, usually?
Along with that antibiotic prophylaxis, she is a postmenopausal woman, so
Yeah.
give her estrogen, local estrogen.
Okay.
And before, at the first visit itself, examine, local examination to look, if there's any mesh-related complication after TOT. The dysuria frequency could also be, this is a proven UTI, but still before we see the cultures examination, again, I stress on that point because I've seen many patients being, this is completely unrelated, but I'll just tell you one patient who had been diagnosed and treated as overactive bladder. I found a VVF in that patient. So there is some constraint, I understand, but always make it a point to examine. Even if the patient has some hesitancy, take the help of your colleague, because that will tell you so many other things which the investigations may not.
So what will be your-
rule out erosion? That's what I mean
Yeah.
to say. Yeah.
Yeah. Ma'am, what will be your follow-up period for this patient? If you call this second episode, should we call her again routinely, or whenever she develops some symptom?
See, put her on prophylaxis. I would not give her antibiotic prophylaxis. You give her estrogen, Call her after a couple of months. If she is symptomatic, she
Estrogen
will
as
definitely
prophylaxis.
call. Yeah, to prevent further
Okay.
infections post
No
menopausal
other non-antibiotic or antiseptic.
Antibiotic is not antibiotic prophylaxis. You cover her up with estrogen. If she still develops another episode, definitely antibiotic prophylaxis.
Okay. Ma'am, is there any role of cystoscopy in this case, sir?
Well,
PVR is only 11 ml.
Well, my opinion is that if patients like this present with recurrent UTIs, here I agree with Dr. Pradhan that a postmenopausal state can cause fibrosis, dryness of the passages, and shrinkage, and the flow rate actually means usually doesn't mean nothing. We are often surprised when we do a cystoscopy that we find the urethra to be quite rigid, and I would. If you do urodynamics and you do serial flow rates, you'll probably may find that these people have some sort of urethral obstruction, stenosis and obstruction. So I'm in favor of doing a cystoscopy
In this patient.
at some stage.
Okay.
Cystoscopy I do for a different reason also here, to see again if there's any mesh-related complication.
Of course.
Okay.
Of course.
Sir, this is a common question. Should we send patient to the other OPD, gastroenterology for chronic constipation, or should we treat it?
Well,
If
there-
we,
this
we
is-
should we should think that this is the cause for recurrent UTI.
I think it behoves upon us to advise the patient on lifestyle measures for preventing recurrent UTIs, be it a postmenopausal, premenopausal, be it postcoital or other UTIs. That are good bladder habits and good bowel habits are essential. And I think we have enough knowledge of medicine to treat chronic constipation, isn't
Okay.
it?
Okay, sir.
So, and usually in this day of information overload, I often tell my patients, go and find out what a high fiber diet is, do your own research and treat your constipation.
Okay.
So
Thank you, sir. Yes,
should
sir.
know what are the red flags of constipation. A patient who is chronically constipated since 5 years, there is no point sending the patient for gastroenterologist. But you find the new onset constipation. Yes, this patient needs investigation, elderly patient.
Okay.
Otherwise, any patient recurrent UTI, you have to treat chronic constipation.
We should treat it. Okay. Thank you, sir. We will take it. So these are second case. This small. Yes, sir. Yes, sir.
Two things. One is alkalizer.
Yes,
It is useless. To make the urine alkaline, you have to give a very large amount of alkalizer, which is not possible because it will be converted to carbon dioxide and water. And so it is useless, but everybody is prescribing alkalizer. Second is, all the doctors, they will...
So that's why I'm
drink-
asking, so why they are using despite...
I don't know.
Okay, sir.
I don't use.
Okay.
Anyway, another thing, all the doctors, they will sell that plenty of water. Also, they are prescribing. What does it mean? One patient is drinking 5-6 liters. Well, why? A doctor said me to drink. Because we have to know how much is the urine output of adult, 1.5 liter. Insensible loss is 0.5 liter. So 2 liters. One should not take more than 2 liters. If it is elderly lady with a cardiac problem, she will go to heart failure. She will go to heart failure or increased frequency. Those are having increased frequency, they will wait all the time. Because especially for the postgraduate, I would say be specific. Be specific. Don't write plenty of, it is a vague in
Especially in CKD,
Yes,
old
special-
patient,
no,
kidney,
plenty,
heart failure patient.
It is a vague term.
Yes, sir.
It has no place in science. And in this case, as Kullan has mentioned, all the cases I do cystoscopy, you will see at least mild trabeculation, you will find it, and dilate it, put her on estrogen, the manipulation means hormone replacement therapy, and I have prescribed so many thousands of women with estrogen. Gynecologists, they fear
Estrogen ointment cream, sir.
both.
Local application.
Local
only,
and also
not the tablet.
I have not encountered any breast cancer because it is in the literature 1 in 40,000 incidence of breast cancer. I've read through all these things. And second is that I put them on a urinary prophylaxis, not antibiotic, urinary antiseptics. Usually I use trimethoprim. In England also they use very cheap for 3 months. For 3 months, if you like, along with that, to increase this, diminish the epithelial adhesion, you can use Canberry, or tell them a glass of Canberry juice a day. This
Okay,
is
sir.
my protocol.
Thank you, sir.
And I have seen they are very well with this regime.
So coming to the second case, 42-year-old lady came to the OPD. Physically tense, severe dysuria, urinary frequency, occasional urgency, and one episode of hematuria. So she had history of low-grade fever yesterday, but not today. She had taken alkalizer syrup from Never Advice with some relief. No comorbidities. So how should we approach Dr. Tiwari?
Urine routine and culture.
Patient came in the evening OPD, maybe 3, 4, 5, 6. Maybe all lab will be stopped after 5 p.m. taking samples. So should we wait for the culture or start the antibiotic, whatever?
At least we can get urine routine. If there are labs which can do urine routine in 2 hours.
Okay.
If not done, then next morning urine routine and then giving antibiotic. At present, start with alkalizer only.
Madam,
I will start the antibiotic, but ask the patient to first give the sample in the lab and then start the antibiotic immediately.
maybe in the evening no lab is open to take the sample. That is a problem.
Okay, then empirically I will start the antibiotic.
Okay. Ma'am,
Because
what
she-
about the urine sample? It is the early morning or fast sample, or any time patient can give the sample? What is the advice?
Anytime.
Fresh
is-
sample. Okay.
And also this patient would need imaging because she has hematuria.
Okay. This is the imaging is needed, there is the ultrasound.
Yeah.
So does this patient is admission, ma'am? Patient
No.
is physically tense,
No.
one patient hematuria? No. So we can assure patients with antibiotics and some tests that patient will relieve with this
Yes.
medication. Sir, any comment?
So I think this is a 42-year-old lady without any comorbidity or any functional deformity. So it classifies as a acute uncomplicated cystitis, female patient. So if we go by the book teaching or the guidelines, we do not need any urine culture in this type of patients unless the patient has history of some intervention or a telltale sign of obstruction, or the patient has history of recurrent documented UTI. This patient, I would rather go for a straightforward urine culture and observe the patient for fever, because normally acute cystitis should not cause fever. The patient has low-grade fever.
Yesterday,
But
not
if I
today.
think the patient has a high-grade fever or there is clinical features, I would suggest this patient is acute pyelonephritis, then this role of admissions and all those things will come.
Sir, how should you document this infection? Always we try to write only the UTI. Is this the right way, or you should describe acute cystitis, complicated uncomplicated, or pyelonephritis or urethritis? How should write it?
Acute cystitis. Yes.
So at least you can write cystitis rather than UTI. Yeah.
Regarding hematuria and cystoscopy, cystoscopy is only indicated if there is a recurrent hematuria, if you suspect a foreign body, if there is an infection with proteus infection, because that may be associated with stone diseases, or there is known or proven case of a stone in the previous history, then only usually cystoscopy is required in cases of uncomplicated UTI. Otherwise, with multiple episodes of hematuria.
Okay. So this patient got relief with 3 days of antibiotic course, and patient does not come again with E. coli positivity.
Just one comment.
Yes, sir.
In England, those who have worked here, when this patient comes in the emergency, they used to do, sister used to do deep state. Take the sample of urine, dip it, you will get all or most of the, whether infection or other things, whether there is any blood or anything, it will show. I don't think that dipstick is available in India.
It is available.
It is available.
In your own 16
Yeah.
chamber.
Okay.
That is in emergency, that is available in all the hospitals there. So you can have an idea. Then if possible, in the hospital also, you can keep a specimen, keep it in the fridge, and start your, if it is acute, then you can start easily with whatever, not phosphomycin along with other drugs. Then you will, after 3 days, you will get your other reports, mean culture report, ultrasonography, and then you can know. And another term I want to sort of highlight, radiologist on report what their cystitis changes. Can a radiologist say cystitis changes? Is it a pathological condition? Means radiology cannot say. I don't know why they are writing cystitis changes. Because those trabeculated, saculated bladder, it looks like crenated, and they will say this is a cystitis.
And that promoted patient to come to us.
That one, this postgraduate should know that
Yeah.
that should not be taken as a guarantee.
Yes, sir.
From the ultrasonography, it is cystitis. That I am coming across every day. They are writing cystitis changes.
Yeah.
What does it mean?
Yeah, today only one patient asked me, yeah, madam, there is cystitis. Are you giving me antibiotics? I said cystitis is not a radiological diagnosis. They should only mention as thickened bladder wall or
Yeah,
whatever.
yeah.
At least we are thankful to the radiologists for giving us patients for that.
Devanshu sir, one question only. If all are sensitive, all antibiotic are sensitive in this case, so what will be your ideal antibiotic in this case?
See, the guideline is very clear. Whether it is fosfomycin or Septrin, that cotrimoxazole, that should be the first diagnosis. So if it is sensitive to fosfomycin, I'll go for this. Or if the patient is not
Single
sensitive,
dose?
Yes.
Okay. Yes, Dr. Tiwari.
Yeah, I beg to differ from this space because most of the patients of UTI have increased frequency of urination, and we ask them to drink plenty of waters. Now, the recommended for fosfomycin is to hold urine for next 2 hours. Now, patient having acute UTI cannot hold urine for 2 hours, and we are giving fosfomycin as a single dose treatment. I think it's a little illogical.
Contradictory to what?
See, all the studies has been done in cystitis patients only, and it was proven. So whether the patient holds it for 2 hours or not, that is immaterial.
Madam,
My
your
choice
comment.
would be fosfomycin. It will
Fosfomycin.
increase the patient compliance and
Yeah.
very
Kollan sir.
I don't know. We are come from an era when we are very happy with fluoroquinolones. So now there's bad press with tuberculosis and
Resistance pattern.
And cephalosporins are very safe because they don't cause. There are usually no allergies and all. Fosfomycin has limitations. It has side effects. So it's a toss-up, really. Depends on individual patients. Most of the times, maybe I feel that I would probably use a cephalosporin or a fosfomycin or even nitrofurantoin. But if it's really a hot UTI with fever and severe strangury, impossible, very severe symptoms, then I would treat it with either a cephalosporin or a ciprofloxacin.
Okay, sir.
But I wanted to just stress something which Professor Debangshu brought out, which is amongst the non-antibiotic treatments for acute cystitis symptoms. He has mentioned non-steroidals, which are very, very good. He has which has not come up today is the use of phenazopyridine or pyridium,
Yes,
which
sir.
is very, very effective and safe. And these can tide you. Even if you sit to see the patient at 10 p.m. in your clinic, you can cover the night with an NSAID and pyridium and alkalizer and put the culture following morning and
Yes, sir.
treat it. So
Yeah,
I
yeah,
think that's my approach.
So coming to the quick case 3, young lady already engagement ceremony done, came with fever, dysuria, low back pain. This happened our physical relation. No previous history of similar episode. What will be your approach in this case, Devanshu sir? Ma'am have already told some part in your lecture.
Probably this is a postcoital cystitis, but if the patient has high-grade fever, I would think the patient might be having acute pyelonephritis. What is the grade of fever in this patient? Patient has back pain also.
Yeah, back pain around 100, 101.
101.
Yeah.
Probably the patient has a pyelonephritis. So this patient needs urine culture definitely. This patient needs a radiological investigation in the form of USG.
Oh.
Otherwise, treatment will be same. Not nitrofurantoin because the patient is having fever. This patient can be better treated better treated by either cephalosporins or aminoglycoside plus cloamoxiclav, not with
Aminoglycoside?
nitrofurantoin.
Aminoglycoside, sir,
Aminoglycoside plus cephalosporins
for
or
IV,
fluoroquinolones,
IV
yes.
or IM.
Or aminoglycoside is always IM. Sorry, IV.
So does this patient need admission also, sir, or?
No, any patient with fever does not need admission.
Okay.
Okay, if the patient does not have any other systemic signs other than fever, she may not be admitted. Okay, all patients of pyelonephritis there is a thing called domiciliary treatment of acute pyelonephritis. Depending on the patient, where the patient is coming from, other comorbidities, you decide. It's not a must that you need to admit this patient.
Okay. Madam, your comment?
Yeah, I'll just give her oral fluoroquinolones, and she need not be hospitalized. And male partner evaluation is not required.
Okay.
We all know that it is related to coitus, but we have to teach the patient, about the importance of voiding soon after the coitus. And
Prophylaxis?
prophylaxis is not required, it's just the first episode. And contraception, not just for UTI, but if it is recurrent only, we advise for barrier contraception.
So this patient got relief with 7 days of antibiotic treatment, oral treatment. Ultrasound said there was no pyelonephritis, completely fine. So after 2 weeks, patient again came. After relation, the same fever, dysuria, low back pain. So in this case, should we give prophylaxis, and what type of prophylaxis, madam?
Postcoital prophylaxis can be given, a single dose.
Single dose.
Single dose,
Nitrofurantoin is sufficient.
yes.
This is a clear-cut case of postcoital UTI.
Yes, sir.
Unfortunate that she had a pyelonephritis first time, but mostly these are cystitis. So you need to teach both the partners what are the non-antibiotic lifestyle changes they should take, like normal hygiene, like peeing after intercourse. These are the normal things. Even after that, if the patient has recurrent episodes of postcoital UTI, yes, either you can give the patient on postcoital single dose, or if it is not effective, put the patient on long-term prophylaxis.
Okay.
I think this pyelonephritis and cystitis, more importance to be given for pyelonephritis rather than cystitis, because that is a very important organ. If there is damage, there will be nephron loss. So that has to be taken ultrasonography is sometimes it cannot evaluate. I think CT scan should be done. How much it is the swelling, what is the grade of infection, whether there is abscess formation or like that. That has to be, kidney should be treated very vigorously. This cystitis does not care. And this postcoital means, what I advise, take a tablet before and a big glass of water, more than 200 ml water. And after go to the toilet, empty the bladder. Then that will prevent this thing. At least she wants to have some more water so that she can, after intercourse, she will go to the and empty the bladder. That is very, very important.
Okay, thank you, sir. So I will skipping this case, as sir already mentioned this orthopedic case. So I will have some rapid question to our panelists. Short answer, because already you are no time. Is UTI dangerous? Most of the patients ask in the OPD, sir, is it a dangerous? What should be our answer? Acute cystitis or urethritis, whatever may be. Devanshu sir. Sir.
It can become dangerous.
Okay, so there are so many
you need to categorize patients who are the patients in whom this UTI can be dangerous. You need to follow up this patient and treat. Otherwise, a young patient who is having postcoital cystitis is not a dangerous situation. It's a very common situation, but that becomes dangerous for a pregnant lady. That becomes dangerous for an elderly postmenopausal with voiding difficulty. That becomes dangerous.
Diabetic.
Complicated UTI, all complicated.
If there is a fever, if the USG is not normal, there is abnormality in USG, suppose stones, foreign body, other things, then it may be dangerous. Otherwise, it's
Okay.
uncomplicated UTI is usually not dangerous. It may be resolving.
Okay. So, how to collect urine in obese female, ma'am? How to instruct the patient because they are self-collection? What is the proper way of collecting urine, especially in obese elderly female?
Yeah, spread out the labia, clean the parts, and then catch the midstream specimen.
Okay.
Ideally, it should be done by two persons.
Refer
Otherwise,
to?
by two persons. Somebody should stretch it.
Yeah, that is very difficult to
stretch it
collect.
And then urine should be collected. Otherwise, it should be contaminated by outside skin.
Is Kullan sir, is it safe home collection? Most of the lab are doing home collection. Is it safe for quality assurance? Would you allow it, sir?
We don't have a choice. Not everyone can come to a hospital clinic and be guided by a clinic nurse how to collect urine or have a catheterized specimen. So yes, proper instructions must be given.
Okay, with proper instruction, we can allow home collection.
Why not?
See,
So-
there are two issues. One is how to collect, and second is how quickly it has to be transported to the lab.
Yes, sir.
Normally, what happens? A person who is roaming about with a collection, he collects one urine at 8 a.m. in the morning, one at 8:30, one at 9, and reaching the lab at 1 p.m. That should not be done. You should have a bag which can maintain the temperature at 4 degrees centigrade, proper collection bag. You can't do a home collection. Collection is not different.
Yes, sir.
You have
But
to
that
give a
depends on the
proper-
collection guy or the
Yes.
laboratory quality checks. It's very difficult from our perspective to maintain that.
Actually, suprapubic puncture, although it is invasive in children and women, that is the ideal urine for culture.
Sir, most of the time it is done
So-
for child, not for young.
How to keep the perineal clean, Kullan sir, for the young or lady for recurrent UTI? Whatever commercial you,
She's the.
ma'am.
We already discussed, I don't advise, actually, patients who come, to our.
Is the only water?
Yeah, only water.
Okay,
No soaps or no other chemical washes. Sir.
okay. So use of publicity we already discussed, so we should not discuss again. So should we prescribe fosfomycin prophylaxis routinely? Because not only urologists, everyone prescribing fosfomycin here and there, especially the medicine, critical care, physician, everyone. It will have a fluoroquinone-like moment where more than 30-40% will be resistance. So should we give routinely to our patients? Or there is group of patients, selected patients that we have to give, sir?
Fosfomycin indications are very clear. It's not indicated for routine prophylaxis in UTI. There are other antibiotics which are given half dose, 1/4 dose Septran or half dose nitrofurantoin or 125 cephalexin. These are normally prescribed. Although many of us are using this, but I don't know, sir. Fosfomycin routinely prophylaxis.
I don't usually. It's not recommended.
This is one of the cause in elderly women, especially with indwelling catheter. That is
Yes, sir, obviously.
because if there is no perineal
Yes.
sort of cleaning
Your
regularly,
animal,
there is a very chance of development of infection.
I usually use fosfomycin for prophylaxis because when the patient come with the uncontrolled diabetes, so we have seen that actually control of the diabetes will eradicate the infection. But if the patient come with a HbA1c 12, so that time I give fosfomycin, and it is written in the book. Once in 10 days you can give.
once in 10 days.
Once in 10 days. And the many patients is there. They are good. The problem is that fosfomycin resistance may develop. One patient or two patient I can remember, fosfomycin resistance has developed. But how long you continue the prophylaxis? That is the main question. So how do you monitor the diabetic status? So 3 monthly HbA1c should below a controllable limit, then only we stop it, the fosfomycin. But the problem is only that fosfomycin resistance usually develops.
Yeah,
So
we
last-
have other options. That's what we've been discussing. Instead of fosfomycin, why not nitrofurantoin? Why not cotrimoxazole? So phosphomycin, we usually, in my practice, I use it to treat the acute episode, not as a long-term prophylaxis.
Thank you, sir. Thank you all.
Another, sir, regarding the collection of the urine sample, I want to say one story of our patients. So one of the patients came to us with a recurrent UTI. She has been suffering from last 2014. Entire West Bengal she has visited. So we usually collect the urine not by the midstream collection. We usually put Nileton catheter, collect the urine directly. Why I'm telling you that these patients, we send the urine culture, it is showing E. coli and multiple pus cell. We give antibiotic. The patient does not respond. Then once I did a Nileton catheter, and this bacteria came as quite unusual, diphtheroid. Clostridium something diphtheroids, and without an unusual antibiotics like that. And we gave in, and the patient responded nicely. We also published it in the BAGU.
Oh, thank you. Thank you so much. That's something unnatural. We are really thankful to our panelists. We would like to give them with some warm appreciation. We invite our president director and Bimolesh to present them with some flowers as a warm show of appreciation. Thanks to Demonsu sir for coming with us. Thank you, ma'am. Thank you, ma'am. And thank you, sir, also. Thank you. With that, we'd like to end of today's seminar. And I would like to thank everybody for making this and coming in. Thank you. একটা ছবি তুলে না